But one of the things that I think I've seen in the emergency room and and heard from some of y'all is that even though we have a policy, there's still a lot of uncertainty about sort of what to do with buprenorphine and when to use it and how to sort of deal with these nuanced cases. So I wanted to hopefully address some of that. Unfortunately, I don't have any financial disclosures, maybe one day. But today we're going to review a little bit about the opioid crisis. I don't feel like I have to belabor that point with you guys working in DC. You probably see plenty of that. Talk a little bit about the history of our treatment of opioid use disorder and why we've been so bad at it historically, and then look at ways that we can treat opioid use disorder more effectively in the inpatient setting, and for any of you interested in the clinic, a little bit in the clinic setting. So without totally beating a dead horse here, we are not doing well as far as the addiction crisis. The numbers, I was a little bit surprised by this data because the numbers over the past several years have been showing over 100,000 deaths each year from overdose. When I looked back at the CDC data, they're now reducing those numbers to about 70,000 deaths a year from all-cause overdose. Still a huge number. And a lot of the patients that we're seeing nationally, a lot of patients we're seeing in DC that are dying of overdoses have opportunities for intervention that we're just missing. So looking at this in terms of how does this affect us as healthcare providers, nationally, we're seeing over 100,000 patients coming to the ER with non-fatal overdoses. We're admitting over 50,000 people annually to the hospital with non-fatal opioid overdoses. So this is a really big percentage of our patient population, and a lot of them are just not receiving care. Looking at this as in terms of sort of a policy lens of why do we care about this? How do we make evidence-based policy about this? This is really expensive. This is an expensive problem. So the estimates vary. The most recent high quality sort of estimate that I could find was based on 2018 dollars. That's close to $800 billion annually. About 90 billion of that is coming from excess healthcare costs. A lot of it's coming from increased mortality. This is an expensive problem. So it's affecting our patients. We're having a lot of deaths. It's affecting our workloads. It's affecting, for the economists in the room, it's affecting our taxes and our expenditures. When we look at DC specifically, DC is notoriously bad at addiction and overdoses. The past several years, we've had the highest per capita rate of overdose deaths in the country. This is the all drug, all cause mortality. When you separate it out, it's mostly from opioids. We're still number one if you separate it out by drug. And even in DC, we're seeing a lot of patients that are coming in that have opportunities for treatment and opportunities for intervention that we're just missing. This is also a huge health equity issue. In all states, we see increased all-cause mortality in patients that are low income, patients that are minority status or undocumented, patients with a history of incarceration with co-occurring mental health disorders, anyone who speaks English as a second language, unhoused patients, and particularly in, this isn't DC relevant, but particularly in Medicaid non-expansion states, we have much higher rates of overdose and much higher rates of mortality. So looking specifically at DC, as you can see, the people that are dying of opioid overdoses in DC are predominantly Black men in their 50s. This is not representative of who has opioid use disorder in the country. This is just who's dying of opioid use disorder in DC. So again, we're missing a lot of opportunities to treat these patients. Of all patients that we see nationally, about 4% of patients that we're treating have opioid use disorder. About a quarter of patients with opioid use disorder are receiving any sort of medication for opioid use disorder. A lot of the people that are dying of opioid use disorder, this is the DC numbers, about 82% have opportunities for intervention, including Narcan, including being incarcerated and having opportunity to initiate treatment there, having a mental health disorder, being in the healthcare setting, and they're still not receiving the treatment needed to prevent these deaths. Again, these sort of failures are compounded in marginalized populations. Of the patients receiving medication for opioid use disorder, there's also racial disparities in what treatment they're being offered. So we see a lot of this in DC. A lot of our patient population, especially our Black male patients, are expressing a preference for methadone. Not a lot of minority patients are offered buprenorphine, and fewer minority patients are selecting buprenorphine, which a little bit is based in sort of patient preference and is somewhat just based in, we offer buprenorphine to predominantly wealthy white women is who really gets a lot of buprenorphine and who's treated well with buprenorphine. So something to unpack. Obviously, we have to keep patient preference in mind, but it's also something that we're not offering treatment equally across our patient populations. So what do we do about this? I'm framing this as a talk for generalists. So I know most of you are not going to go into addiction treatment. I do not have a degree in addiction treatment. This is like a very self-taught thing for me. But I think it's an issue that affects all of us, partly because, as we talked about, these patients are coming into the ED, these patients are coming into the hospital. But sort of more importantly, these patients just aren't getting treatment. There are not a lot of addiction providers in the country. There's huge geographic variability in the access to treatment, to addiction treatment. So for instance, about 80% of counties don't have a methadone clinic. So for a lot of patients, trying to access addiction treatment is just, essentially impossible. It requires a lot of transportation. It requires a lot of coordination that a lot of patients, particularly with opioid use disorder, might not have access to or have sort of the resources they need to actually seek. We're seeing between 2 and 6 million patients nationally with opioid use disorder. These are going to be your patients. And from the perspective of just making our own lives easier, treating patients with opioid use disorder makes your other medical care easier. So it increases compliance with antibiotics, it increases compliance with your other treatment plans, it reduces overdose mortality. These are already going to be your patients, and treating them with MOUD is going to make your life easier as far as controlling their blood pressure, controlling their diabetes, keeping them from getting endocarditis. In the hospital setting, only about 20% of patients are receiving MOUD of any sort. And then just sort of most importantly, MOUD works. This is something that I think historically, like when I was in residency, my program director didn't believe in buprenorphine. We didn't learn anything about buprenorphine. The literature is in, buprenorphine works. It reduces mortality, it reduces overdoses. It helps in pretty much every metric you can look at. And it works better than pretty much anything else you can do for OUD. So there's been this conversation in this sort of culture of you have to do talk therapy, you have to do AA or NA in order to be engaged in any sort of treatment. That's not best practice. The literature supports if you do nothing else, if you can't provide housing stability, if you can't provide insurance, if you can get the patient on buprenorphine, you will keep them alive. So there are 3 main options for how we can actually treat opioid use disorder. You guys all know this. The FDA-approved treatments are buprenorphine, methadone, and naltrexone. I'm going to talk mostly about buprenorphine, but I wanted to give you a little bit of a context for why. When we're looking at the efficacy of these medications, buprenorphine and methadone have good evidence that they reduce mortality for patients with OUD. Naltrexone doesn't actually have a lot of evidence that it reduces mortality. Naltrexone has been demonstrated to increase abstinence from drugs, but it doesn't actually increase or improve mortality survival because the rates of overdose when you come off of naltrexone are so much higher. From a logistical perspective, this is why I prefer buprenorphine over methadone. I'm sure you guys Thaddeus just walked in, have talked to Thaddeus about the difficulty of getting patients into methadone clinics, especially for our non-ambulatory patients in DC. From a logistical perspective, you can't give someone methadone in your clinic. That might change in 5 years, but right now it's just not something that's logistically feasible for you guys to do. And then just looking at the cost efficacy, quality of life, methadone and buprenorphine are both cost effective relative to naltrexone. I would make the argument that buprenorphine has higher quality of life improvements because you're not bound to a methadone clinic every single day. So part of this is logistics. What can you actually do from clinic is buprenorphine and naltrexone. What actually works from clinic is buprenorphine. So we're going to talk about buprenorphine so much that you will be sick of it. I apologize. We're going to go deep in the pharmacology weeds for about 3 minutes. I promise this won't be too bad. So looking at how do opioids work, opioids have main effects on a lot of receptors, but 4 main receptors. The ones that we're going to talk about the most are the mu-opioid receptors. That's what matters to us as far as analgesia. That's what matters as far as respiratory depression, overdose, constipation, euphoria, sedation, all of those things. That's also the only receptor that buprenorphine really has an effect on. So heroin, methadone, all of the other opioids have effects on all receptors. Buprenorphine focuses on the mu-opioid receptor. So I do not remember a single thing about S-curves from first year of medical school. I asked our ER pharmacist, she did not either, so I do not have a better explanation of this. But the short version of this is a paper in 2011 looked at basically every opioid on the market, and as far as how strongly does it bind to the mu-opioid receptor, how quickly does it dissociate, things like that. The short version of this is there's low, medium, and high binding affinities. The things that I want to draw your attention to are oxycodone, methadone, fentanyl, morphine are all in that sort of middle category. And then buprenorphine, Dilaudid, and sufentanil are all in that high binding affinity category. Also, I'll draw your attention to the naloxone is it's close to being high affinity, but it's sort of the high range of medium affinity as far as binding to the opioid receptor. Why does this matter? This makes buprenorphine a kind of weird medication. So it's got an extremely high affinity. So what this means for us is if you have morphine on your receptors, if you have fentanyl on your receptors, and you add buprenorphine in, it's going to knock everything off of your mu opioid receptors. So this is essentially this is what we're going to be talking about the rest of this lecture. This is how buprenorphine works. It has a really long half-life. Half-life varies by patient, but between 24 and 60 hours. It has really strong pain effects. It still works at those mu opioid receptors, although the half-life for the analgesic effects is a little bit shorter. And then one of the things that's unique about buprenorphine, because it's a partial agonist, it works at the mu opioid receptors, but it doesn't fully fill essentially the mu opioid receptors. So it has some respiratory depression effects, but it's not hitting that receptor as fully as other agonists are. So it has an extremely minimal effect on respiratory effort. So they've done a bunch of really insane studies on this where they tried to overdose with people with buprenorphine and tried to overdose people with fentanyl. And the long and short of it is there's a ceiling effect to how much buprenorphine is going to affect your respiratory depression that caps out usually about 12 milligrams. So above 12 milligrams of buprenorphine, you're not going to get any more respiratory depression above that. So if you get them to 12 and they are still breathing, you can basically just keep going and you're not going to have increased respiratory depression effects. The other thing that's interesting about buprenorphine is it's one of the medications that for addiction specifically, it has very, very dose-dependent effects. So it depends on the saturation of the mu opioid receptor, which again is a little bit variable by dose for every patient. But essentially, when we're treating addiction, the first thing we're usually trying to do is address withdrawal. You have to get about 50% of receptors covered to address withdrawal. But then longer term, to maintain sobriety, one of the things we're trying to address is preventing cravings, which takes about 80% of receptor occupancy. Or for patients who are prone to returning to use, you can actually block the effects of other drugs with about 90% receptor occupancy. So they did a study, this is my favorite study because I don't know how they got approval for it, but they loaded people on buprenorphine, on really high dose buprenorphine, and then they tried to intentionally overdose them on fentanyl, and they couldn't do it. So the control group that didn't get buprenorphine and just got fentanyl just got really sedated really fast. So it's a really fun paper if you're interested. But anyway, so what we're seeing is for patients that, especially patients with sort of unsafe living situations or situations where they're likely to return to use, if you can get them on a lot of buprenorphine, they're not going to get high, they're not going to overdose, they're safe. Like you are literally keeping them alive. Buprenorphine has been used experimentally and sort of on the street as a reversal agent, again, because of this binding affinity. It knocks everything off the receptors. If you're overdosed and you don't have Narcan, people on the streets essentially are putting buprenorphine under their tongue and reversing overdoses. They've done that a couple of times in other countries as well for methadone overdoses and things that are hard to reverse with naloxone. So anyway, buprenorphine's weird. It's an opioid agonist. It's a weird opioid agonist. So I'm sorry for making you look at S-curves, so we won't do it again. I wanted to stop for a minute. Normally this slide is much later in this lecture, but I realized that every slide that I have talking about dosing and initiation strategies for buprenorphine, every single slide was like, but watch out for precipitated withdrawal. And I figured if I talked about a bunch of strategies and didn't really explain what we're actually worried about with buprenorphine initiation, I would lose you immediately. So because of the pharmacology of buprenorphine, we're not worried about overdose with buprenorphine. You are not going to cause somebody an overdose that has significant respiratory effects with buprenorphine. It's just not going to happen. The thing that you're worried about with buprenorphine is precipitated withdrawal. So essentially what this is it's the slamming on the brakes effect. If you've got a bunch of fentanyl on your receptors, you knock all of that off with buprenorphine, which does not have euphoric effects. It's like you're going 120 miles an hour, you slam on the brakes, you're going 20 miles an hour, those receptors are still filled, but you're going to feel it. So this is sort of the biggest risk for patients because it makes people feel terrible. So this is basically, it's almost like Narcaning someone, it puts someone in acute withdrawal. And for buprenorphine, this is dangerous because it discourages use of this medication basically for the rest of their life. If you precip someone badly and you don't get them comfortable, they're not going to use buprenorphine again. So this is the thing that's the biggest risk for these patients. Um, it's more common in certain patients. So if someone uses fentanyl and you give them buprenorphine 5 minutes later, they're going to precip. They're not going to be happy with you. It's more common in methadone. It might be a little bit more common in sort of our population because we have so much fentanyl. The literature on this is still sort of mixed of whether fentanyl patients have higher rates of precipitated withdrawal or not. So this is what we're afraid of. It is uncommon. We're afraid of this. We talk about this a lot. It's about 1% of patients actually have precipitated withdrawal. So look out for it, but it's not going to happen that much. So we're afraid of this. We're going to go ahead and talk about what we do about it because it is a risk. It is something that's going to scare you. But it shouldn't scare you because the treatment for precipitated withdrawal, pretty much no matter what, but even if it comes from buprenorphine, is giving more buprenorphine. Basically, what we see is this happens when the receptors aren't fully filled, and all you really need to do is fill every receptor with buprenorphine, and that usually helps symptoms. So this affects how I approach buprenorphine. We'll talk about that when we get to the ED management a little bit. But from the perspective of should you be afraid of doing this in the healthcare setting? No, we have an order set that will treat this. You're going to be okay. The sort of second line management, other than getting more buprenorphine on, is just treating the symptoms. So treating nausea, treating diarrhea, treating body aches. If you really get yourself in a hole and you can't get more buprenorphine on, you can't get the patient comfortable, you can use low dose ketamine, like 0.1 to 0.3 mg per kg of ketamine. You can use antipsychotics, you can use benzos, whatever you need to get the patient comfortable, with the goal of then getting the rest of their buprenorphine on them. And then if all else fails, you can just give them Dilaudid until they feel better. So how do we actually use buprenorphine? Now that we know what our worst case scenario is, what do we actually do with it? So the patient selection for buprenorphine, and I think even in the order set we have here, it still has kind of a lot of contraindications, which are kind of not necessary. The only patients that can't take buprenorphine are patients who say, I don't want to take buprenorphine, and you can't talk them into it, and patients that have a true allergy. Pretty much everyone else can take buprenorphine. If they're on methadone, it's a little bit harder to get them on buprenorphine. It's not impossible. If they're pregnant, it's fine. We'll talk about that a little bit later. Pediatric patients are a little bit challenging just because of some legal and logistical things for our med-peds friends, but it's not totally impossible. Pretty much any patient can be on buprenorphine. So basically, what you have to do is identify opioid use disorder, which is having more than 2 checkboxes on your DSM criteria for opioid use disorder, and then documenting if they are in withdrawal. You should not start buprenorphine until they are already in withdrawal. You are going to make them sick. I have on here as a relative contraindication patients that have a painful condition. If they're having surgery, if they have a broken bone that needs full agonist for pain control, as a relative contraindication. It's not impossible, it's just a little bit tricky. We'll talk about strategies for that. So the COWS score is the opioid equivalent of the CWA. It's the opioid withdrawal scale. This is a nursing order for us. You do not have to memorize this. The number that you really need to know is for inpatient purposes, COWS needs to be at least 10 to 12. For the ED, we have a little bit lower threshold. COWS needs to be 8. And that's basically just, are they in mild to moderate withdrawal? So this is what you guys are doing most of the time. This is your order set. This is I'll show you the order set in a second, but if you look for what's CPG for MedStar, how do we treat opioid withdrawal? This is what you guys are doing in the inpatient side. Basically, you're waiting until the patient's in mild to moderate withdrawal, so a COWS of 10 to 12, and then you're giving them 4 milligrams of buprenorphine and you're sort of seeing what happens. If they are about the same, a little bit better, you can repeat your dose at 4 hours. You can go up to 12 milligrams on the first day. If they are much worse, they are in precipitated withdrawal, and you can go up to 24 milligrams on the first day. If they feel 100% after 4 milligrams, you can just stop. That's not going to happen very often in DC. Most patients in DC need 16 to 24 milligrams before they're really feeling better. But this is it. There's a nice little order set for you guys. Here's your order set. If you can't read it, the search bar is it's opioid withdrawal acute new is the one that works for you guys on the inpatient setting. The way the orders are written for buprenorphine, it sort of looks like it caps out at 12 milligrams on the first day. The CPG itself does specifically clarify if the patient is in precipitated withdrawal, you can keep redosing up to 24 milligrams. So just don't be too afraid of that. The order set I think is super helpful. It's got I believe it's got the referral to peer recovery coaches in it. It's got all the adjuncts, and it's got all of your references. It's got the COWS score, it's got the DSM criteria, it's got the CPG all included in the order set. So I do like that. The thing that I think I've gotten more questions from you guys about is, what about patients that are on methadone? What about patients that they've been here for 2 weeks, they had surgery, and now they're on oxy every 4 hours. How do we get those patients onto buprenorphine for discharge? And these are sort of the challenging ones. So this is what I think is a little bit more interesting, partly because all the literature of this is essentially, there's some case studies that are essentially drawing from the experience of drug users on sort of like the dark net. And now we've all just started recreating these protocols, which I think is fun. But the general approach to this is you're trying to sneak buprenorphine on your unoccupied opioid receptors without displacing it. So we know that if I flood someone with a lot of buprenorphine and they've got a bunch of fentanyl on, we're going to displace it. But if someone has fentanyl on board, in most instances, they're going to have some unoccupied receptors, and the half-life of buprenorphine is much longer than fentanyl. So I'm trying to hit a few more of those unoccupied receptors every day without knocking a clinically significant amount of fentanyl off, so the patient doesn't feel this withdrawal syndrome. So this is mostly done in peer-reviewed literature. It's mostly done in the inpatient setting. This is an approach that has been done with sort of illicit street drugs by patients who have just sort of figured this out on their own. So theoretically, you can do this in the clinic setting. I recommend it mostly in the inpatient setting. I will say there is not a single best practice dosing strategy for this. I've pulled together a couple of sort of sample protocols, but this is a little bit of we're sort of averaging things to figure out the best protocol right now. So this is what I would recommend as a microdosing approach. Again, this is not a super high quality protocol, but this is sort of the amalgamation of a bunch of different protocols that have been reported. The goal is getting the buprenorphine on and weaning the full agonist at the same time. So you can start with basically a quarter, so we have our 4 milligram strips is sort of our standard treatment for buprenorphine. So you can give them a quarter of a strip on the first day, you give a quarter twice a day, gradually increase the buprenorphine. And there's sort of 2 ways you can approach the agonists. You can either continue the agonists at their full dose until you get the patient up to 8 milligrams of Suboxone, and then you just discontinue them altogether. And at that point, all receptors should be occupied. You should be good to go. Or you can wean and space out your agonist doses as you're increasing the Suboxone, sort of as the patient tolerates it. So both have had pretty good success. Both approaches, as far as weaning the agonists, have had pretty good success in case studies. So it's really just a patient tolerance sort of conversation. There are, I believe we have all formulations of buprenorphine on formulary here. So there are a few other approaches for patients that are acutely ill, if they're not tolerating PO or sublingual medications for whatever reason. If they're, we're probably not doing this a ton in patients that are in the ICU, but if you need to, there are other approaches with transdermal and IV patches. Transdermal patches, I think, are probably better for the clinic setting. The dose of the transdermal patch is extremely low. It takes about 3 days to get up to levels, and it turns into about a quarter of a strip. So for patients that you're trying to do this initiation in the outpatient setting, starting with the transdermal patch and then starting with the strips on day 3 or so tends to be an effective way of doing the same thing if it's a patient that's having trouble cutting their strips or someone who just needs a little bit more sort of continuity. So essentially it's the same sort of thing, except you skip the first 2 or 3 days. As far as microdosing, you just put the patch on and it has the same dose effects. The one that I think is more interesting in the inpatient setting is IV buprenorphine. There are far fewer reports of this. IV buprenorphine is traditionally used by anesthesia and pain services, but we do have it. So it is an option for patients that truly cannot take sublingual medication. Just for your dose conversion purposes, the dose of sublingual is 2 to 3 times, the bioavailability of the IV is about 2 to 3 times higher than the sublingual. So reduce your dose by at least half of what you'd be giving sublingually if you're giving it IV. And then you're going to do sort of the same up titration with this that you would with the sublingual, just with that dose adjustment. And then once you get to sort of an effective dose, you can transition to the sublingual tablets or if the patient's not tolerating it, you can continue with the IV. The thing with the IV buprenorphine is the half-life is much shorter because of sort of lipophilic effects. So you do need to increase the frequency of dosing. With most sublingual buprenorphine, you can give it every 12 to every 24 hours. With IV, you probably need to give it every 6 hours. Okay, so what about these really complex cases, or you can't get your attending on board with doing this weird stuff that some woman you've never met taught you in a grand rounds one time? So we do have some resources in DC. We do not have any addiction specialists at Georgetown. We have one addiction specialist who's starting at, I think, Good Sam pretty soon. So hopefully we'll have a referral and a consult service available in the future, but right now we do not have that internally. So sometimes anesthesia, acute pain, palliative will have some recommendations on this, but we also have access to the University of Maryland has a addiction consult service that's free. So if you have a complex case, you need some recommendations on one of these nuanced cases, you're not sure about this microdosing protocol, you can always call DAX, you can send them a request online, or you can send an email, and they will help you with all of the sort of the logistics of this. I wanted to talk a little bit about what we do in the ED, just because theoretically you'll see some of these patients. And if it comes down to it, if you have a really challenging patient that has frequent AMAs because of untreated withdrawal, I think it's reasonable to ask us to sort of do some of this initiation in the ER because we can just do it faster. Our protocol is pretty aggressive, to be honest. For patients with a COWS of greater than 8, we start with 8 milligrams. So you guys normally start with 4, we start with 8. We can go up to 32 milligrams over the course of a couple of hours. This is sort of my baby, honestly, because as we sort of talked about with the management of buprenorphine precipitated withdrawal is more buprenorphine. So in my opinion, let's just start at the end and start with that really high dose because it's less likely to precipitate them and it's going to go ahead and treat that precipitated withdrawal. So we've had pretty good effect with this. As far as I know, I don't think we've had a lot of precipitated withdrawal. Occasionally, you'll still get precipitated withdrawal at 8 milligrams. It's pretty uncommon above 12 milligrams as a loading dose. So if you have a patient that you know is left 4 times against medical advice because of untreated withdrawal and they're in the ER being admitted for a painful condition, if they're in withdrawal already in the ER, you can ask, I can't promise they're going to do it, but you can ask the ER if they'll initiate for you. We have a protocol for this, and pretty much everyone in our ER should know that they can call me if they have questions about this, and I'll talk them through it. Just because it is faster for us. Our protocol goes up to 32 milligrams on the first day. We're all limited at 12. So it is sometimes helpful in reducing those AMA discharges. This is our protocol just for the sake of knowledge. If you're in the ER and you want to try this, our providers are sick of hearing from me and they should know about this. I think I'm going to ignore this. Not sure how to process that. So this is something that I did want to just highlight. So we talked about precipitated withdrawal. So we actually have a precipitated withdrawal subphase order set that it was initially part of the ED buprenorphine initiation order set, but it's actually accessible to y'all as well. So this is just the same philosophy of we're trying to get as much buprenorphine on as possible, but then it's got the refractory protocol for low-dose IV ketamine. I know this is harder for you guys on like med-surg teleates. You can't really give IV ketamine, but if you do have patients that you're concerned about buprenorphine precipitated withdrawal, we do have the order set as a sort of resource for you. I don't know if any of you guys are planning to do clinic-based medicine, but if you are, you can do pretty much any of these strategies as an unobserved initiation. So patients don't have to sit in your office doing repeat doses of buprenorphine all day. You can just send them home with the plan of you're going to wait until you're in withdrawal. Here's your prescription for buprenorphine. You're going to start with 4 milligrams once you feel pretty sick. And if you feel better, you can stop. If you feel worse, you can take 4 more. We have a protocol for this from the ER. Our protocol is to cap at 12 milligrams on the first day. I think it's probably reasonable to have a higher cap for the first day. There's some protocols out of California that will cap at like 32 milligrams, even doing this as a home initiation. And then day 2, you start wherever you ended on day 1, and you can go up to 16 milligrams. So again, if you're in the ER, we have a discharge instruction for this. We have an order set for this. I am happy to send it to you if you guys want to steal it for clinic. I think it's actually a very reasonable, very safe protocol. And if your patient's really afraid of buprenorphine, if they're really concerned about precipitated withdrawal, if they've had bad experiences in the past, you can sort of tailor any of these approaches. You can use the microinduction, you can use the macroinduction based on what's worked for your patient or what hasn't worked for your patients in the past. A lot of people have basically bought buprenorphine on the street and have had bad effects with it. Most people who've had bad effects with buprenorphine have had bad effects they've had precip for a couple of reasons. And it's usually because they either took it too soon or they didn't take enough. So I think having that conversation with your patients about what have you tried in the past? What dose did you take? When did you take it? How did that go for you? Is sort of important in tailoring your approach. And then whatever has worked for them, you can do that again. Whatever hasn't worked for them, try something different. So this is just sort of a sample microinduction for outpatient protocol. I don't like microinductions quite as much in the outpatient setting, just because you're sort of assuming the patient's going to continue using whatever full agonist they're using on the street. For most patients, that is not a prescribed agonist. For most people, that is fentanyl and whatever variants of fentanyl we have in the region. So this is a little bit of a harder one to sort of rationalize, I think, as an outpatient, because you're still exposing your patient to the risk of overdose every day that they are using their sort of illicitly obtained opioids. I still think it's better than not offering them any treatment, but it is just one of those things. I think a lot of people have a little bit of like an ick with this, because you're still saying, well, just keep using your fentanyl and reduce it a little bit every day, but you don't have good dose control. So if these are patients that are willing to come into the hospital and do sort of an induction, I think it's great. If not, I think giving them the best chance of not overdosing requires that we give them buprenorphine, even if they keep using the fentanyl for a week. As we get on the buprenorphine, they are probably going to use the fentanyl for a week anyway. As far as macroinductions, this is not officially a MedStar protocol, but there are some really high dose initiation protocols that have been extremely successful. California Bridge is my favorite resource. I've got resources linked at the end. But if you ever have a question about how you do anything in the inpatient setting, ED setting, clinic setting, California Bridge is your place to go for resources. They have as you can see, very high dose outpatient initiation, like one pager for patients, where basically you just start with 16 and then you can go up to 32. And it's very simple. There's not a lot of math. There's no cutting strips. You just go for it. So just logistically, if you do want to do this in the outpatient setting, right now, there's not a lot of sort of resources within, I think, the MedStar like DPART process as far as how to give patients instructions about this. So if something that you're interested in doing, I would say just go ahead and build a template for what you want your patients to do. It saves you a little bit of time. And then the biggest thing with this is make sure the patient has enough buprenorphine to manage their symptoms. So if you're saying you should take 4 milligrams twice a day and the patient has precip, and you give them a 3-day supply and they burn through that on the first day, they're just not going to be comfortable. So even if you're telling them to start with 4 milligrams, go up to 12 milligrams, you should really assume they're going to need 24 milligrams a day and give them enough to have that, so that if they get sick, they're not just sort of out there with nothing to help them. And where you can, add the adjunct. So give them Zofran, give them clonidine, give them the things they need to manage symptoms. And then just a few things to sort of consider about this. Most of the protocols that we have really like nationally act as though the max dose for most patients is going to be 16 milligrams. I don't think that's true in DC, just because we exclusively have fentanyl as our illicit drug supply in DC. And what we're seeing is that fentanyl requires much higher doses of buprenorphine to prevent withdrawal, to prevent cravings, and to maintain sobriety. So I think most patients in DC are requiring 24 milligrams. And from talking to various addiction providers in the region, that's sort of what they're seeing as well. Some patients will require up to 32 milligrams just to prevent withdrawal and to reduce cravings. There's sort of a lot of conversation about this are you giving people too much? Are they diverting it? Do they really need to be maintained on these doses? I think we have to give people the benefit of the doubt on this. Even if they're diverting buprenorphine, people who buy diverted buprenorphine tend to enter treatment later. So maybe even if they're diverting it, it's actually helping people long term. And there's really no risk of overdose, even when it's diverted. And if the patient's actually on a higher dose of buprenorphine, it increases their retention in treatment, it reduces their illicit use, it blocks overdose, it reduces cravings. So it's one of those things, the efficacy of higher doses is pretty well documented, and the concern about diversion is honestly pretty negligible in my opinion. You're not, even if your patient is selling their buprenorphine, that sold buprenorphine is not going to hurt anybody. So I assume that my patients are taking their medications as prescribed. If I'm wrong, it's still not going to kill anybody. As far as long-term continuation, this is sort of what I do want to highlight for you guys in the clinic setting, in the hospital setting. Buprenorphine is a lifelong medication. Historically, we've looked at MOUD as something that should be weaned over the lifetime. It's not. What we see is that for both methadone and buprenorphine and naltrexone, the period when you come off of these medications or when your risk of overdose is most increased. So this is not a medication you need to come off of. This is lisinopril. This is, you are on this for life. If you stop taking this, your risk of death is increased. If patients are having a lot of side effects and they want to lower their dose, they want to come off of it, it's definitely worth a conversation. But this is not something that you should be afraid of prescribing and continuing the same way you would buprenorphine or lisinopril. Honestly, the hardest period with buprenorphine is the initiation. If you inherit a patient who is already stable on buprenorphine, you really should not be thinking twice about it. Just like refill their prescription every month, no questions. It's not monitored the same way other opioids are. It's not considered a drug of abuse. So it's not something that should be a red flag for you. Buprenorphine can be, I don't think most of y'all are going to take care of pregnant patients very often, but it is safe in pregnancy. So the inpatient order set right currently says that it's a relative contraindication in pregnancy because there's a conversation about buprenorphine as a monotherapy versus buprenorphine with naloxone. The current ASAM guidelines and the ACOG guidelines are that it doesn't matter. It is still safer. You should still treat these patients with buprenorphine, even if it has naloxone, even in pregnancy. The only real consideration in pregnancy is that the metabolism is a little bit different. So these patients more frequently need split dosing because their circulation is so much higher. This is something that is a little bit new, but it's something I do want to talk about. Buprenorphine is originally a pain medicine. It is still an opioid. It does still have full analgesic effect. So patients with chronic pain are actually really good candidates for being transitioned to buprenorphine. And a lot of patients who are transitioned from oxycodone to buprenorphine say they actually have better control and better sort of quality of life being switched to buprenorphine than they did on full agonists. There's a lot of reasons for this. Part of it is reduced sedation, reduced side effect burden. Part of it is most opioids have over time, they develop opioid hyperalgesia. So the more opioids you're on over time, the more pain you have. And the current thought is that buprenorphine actually reverses, at very least does not cause that and probably reverses that effect. So patients that have been on really high dose oxycodone for a long time, if you can get them transitioned to buprenorphine, they actually tend to have less pain and better pain control. It's not universal, but it does tend to work. If you're using buprenorphine for patients with chronic pain, the pain effects, again, are shorter. So pain effects usually last about 6 hours. The half-life for buprenorphine for withdrawal symptoms is closer to 24 hours. But it doesn't matter if you split this dose. If a patient's on 24 milligrams for withdrawal and for maintenance of sobriety, and they say they have chronic pain, just split that 24 into 4 doses. They take 6 milligrams every 6 hours. They have improved pain control, and the total dose for withdrawal management is still the same. Getting patients onto buprenorphine if they're on full agonists is obviously pretty challenging. I think this is one of the things that does come up a lot for you guys inpatient is these surgical patients or patients who are on methadone, transitioning people to a partial agonist is pretty challenging. Getting people from buprenorphine onto a full agonist is much easier. Getting people from a full agonist like methadone onto buprenorphine is much more challenging. So focusing this on methadone, because this is what I've been asked about several times here. In general, if you can get a patient down to about 40 milligrams of methadone, it's reasonable to just give them a 24-hour washout and start with a standard induction. If they're on a much higher dose and you need to transition them to buprenorphine because their QT is prolonged or just because they want to, the goal is to get them down to less than 70, and then I would try a microinduction protocol at that point, either with the IV or with the sublingual buprenorphine. These are the patients that I would call DACs for help, because this is still a really challenging thing. Even for addiction specialists, this does have the risk of precipitated withdrawal. It is possible, but this is where I would call for help. Um, Talking about naloxone a little bit, patients who have received naloxone, especially in the ED, these are actually really good patients to start on buprenorphine because they are in acute withdrawal. They are not happy with us. And naloxone's binding affinity is higher than fentanyl. It's higher than morphine. So even us giving them more agonists in the ER is not going to reverse their withdrawal. Buprenorphine will. So this is, if you have patients, if you're in the ER that are in acute withdrawal, or you have patients on the floor that overdose, you end up Narcaning them and they're super sick. It's actually, I mean, obviously don't give them Narcan with the intention of getting them on buprenorphine unless a patient asks you to, which a few patients will. But if they do have Narcan and they are in acute withdrawal, this is a really good time to start buprenorphine because it actually will reverse that withdrawal. The other side of this is if you think your patient is overdosed on buprenorphine, they probably aren't. They're probably overdosed on something else. So if you have sort of co-occurring benzos, that's more likely to be what's causing the sedation, but also Narcan is usually not going to reverse your buprenorphine if you think there is an overdose. I want to talk a little bit about the different formulations of buprenorphine. We talked about the different forms, IV sublingual, things like that. One thing I did want to highlight, I'm sure you guys all know this, buprenorphine has to be administered sublingually. If your patient swallows it, it does not work. The oral bioavailability is extremely low. The sublingual bioavailability is pretty good. So make sure if your patient says this really is not working for me, I'm really having bad symptoms, make sure they're taking it right. It needs to dissolve under their tongue. They can't talk for 10 minutes, like they can't drink for 10 minutes. It has to actually dissolve. The other thing that will sometimes come up in this population is people say that they're allergic to naloxone or they really don't like the naloxone. The naloxone component in Suboxone and these combo preparations is theoretically not bioavailable if taken sublingually. The point of the naloxone is basically, it's sort of a historical thing of naloxone is not sublingually bioavailable, but if you crush and inject this film or this tablet, the naloxone is supposed to act as a deterrent from abuse. I don't think that makes any sense personally, because we've already talked about the binding affinity of these medications ad nauseum. Even IV, the bioavailability and the binding affinity of buprenorphine is going to be higher than naloxone. The half-life is also much higher. So even if you were to inject this, naloxone's half-life is about 20 minutes. And then the buprenorphine's half-life is several hours. So if you really wanted to abuse this medication by injecting it, you still could. It's still going to work. I don't think the naloxone actually adds a lot of value to this medication. And I don't think it adds a lot of safety to this medication. So if your patient says, I will not take anything with naloxone in it, that's fine. You can give them just plain buprenorphine without the naloxone component. It does not matter. It works just as well. The efficacy is the same. The active ingredient is the buprenorphine. And then I just included this chart because I had never seen it before about 3 days ago of the sort of the dose conversions of Suboxone versus Zubsolv is one of the new brands. I never know what to do with this, so I just included this for my own reference. For all patients, sort of best practice harm reduction things, make sure these patients are connected to our peer recovery coaches. Our peer recovery coaches are better than any of us will ever be at making sure these patients have follow-up and are referred to the appropriate addiction providers. For patients, especially on the inpatient setting, make sure you're screening for HIV, Hep C, pregnancy, co-occurring mental health. Is this patient at risk for endocarditis or skin and soft tissue infections? Look for those things pretty much always. Any patient that you're discharging, you should still be offering Narcan to. If you're giving them buprenorphine, they should get Narcan with it. And then for all patients that you're treating in any context with MOUD, make sure you discuss that increased mortality risk in the period in which they discontinue. So if you've been off of fentanyl for 6 weeks on buprenorphine, you decide to stop using your buprenorphine and you start using fentanyl again, your tolerance has gone down. So the dose of fentanyl that you were using before is much more likely to kill you. So this is a conversation you should have with your patients of, listen, if you return to use, I'm going to say no judgment, no stigma, but do understand that your risk is increased and you need to reduce your dose. And then patients who, I mean, this is not a harm reduction lecture. I will talk about harm reduction, but making sure patients are storing their medication safely and that they understand where to access harm reduction resources in the community. I'm not super time in my no. So this is not a methadone talk. I have a lot of thoughts about methadone, and I think we're going to have a lot of legislative changes about methadone in the next couple of years. But right now, methadone is fairly restricted to you guys. I did just want to talk about sort of 2 situations in which you can use methadone. This is the official Code of Federal Regulations of what you can do with methadone. The short version is if you have a patient inpatient who is in acute withdrawal or who has a medical condition that needs treatment and basically they're in withdrawal, you can start methadone for withdrawal in the inpatient setting. The caveat to this, and this is my specific concession that is if the patient intends to be on methadone for maintenance therapy, you have to make sure they are able to go to an OTP, to a methadone clinic on discharge. So if it's a patient that's going to go to rehab, that's non-ambulatory, that's going to go to a nursing home, in DC, it is extremely challenging, if not impossible, for those patients to access methadone treatment. So those are not good candidates to start on methadone. This is actually maybe a little bit easier to start in the ED for patients that were discharging. We could theoretically discharge straight to a methadone clinic if we needed to, but for the inpatient setting, if you're starting methadone for someone who intends to be on methadone maintenance treatment, talk to Thaddeus, talk to one of the peers first to make sure they are an appropriate candidate, or we end up sort of with this patient who we can't get access to care. This is more relevant sort of depending on where you practice. So DC, we have 3 methadone clinics. A lot of counties, so 80% of counties in the US do not have any access to methadone clinics. So if your patient doesn't have transportation, this is not a good patient to really start on methadone because they're not going to be able to access it. The criteria for who actually is eligible for treatment varies by state. So if you end up practicing somewhere else, talk to your peer recovery coaches and your social workers there to figure out who's a good candidate and just make sure you have a plan before you start methadone. That said, if you are going to start methadone, here's how you do it. This has to be per MedStar CPG. This has to be done by an attending. This is technically fellows are even excluded from this, which I took a little bit of issue with, but having been a fellow here. But basically, it's intending only initiation, screen with an EKG for QT prolongation. And then if the patient is using sort of street opioids, if they're using fentanyl, start them with 30 milligrams. If they're using oxycodone, maybe start lower. Their tolerance is going to be a little bit lower. And then the max dose you can go on day 1 is up to 50 milligrams. So you start at 30, you can give 2 additional doses of 10 milligrams for a max of 50. This is MedStar CPG. This is also just federal law. This is all you can do. So don't go above 50 milligrams on the first day. You can then increase by about 10 milligrams every 3 to 5 days, but the sort of the steady state for methadone is pretty slow. So just don't increase too fast. You'll get sort of stacking doses. If the patient has a history of sort of respiratory failure, respiratory depression, if they're old, if they're on benzos, if they're super ill, consider starting lower. The caveat here, and Thaddeus and I haven't really figured out what to do with this yet. There is specific language in our CPG that if the patient does not intend to continue on methadone as an outpatient, the linkage to treatment piece doesn't matter quite as much. It's one of those, if the patient's going to leave against medical advice, unless you treat their withdrawal and the only thing they'll accept is methadone, but they don't intend to be on methadone, you can treat those patients even if you don't have a connection to an OTP. That's a very sort of weird situation to me. I think I would still probably wait to talk to the peer coaches on that one, unless the patient's just about to walk out the door, and then I might give them a dose. For patients that are already on methadone that you want to continue, I'm sure you guys already know this, you just have to confirm the home dose. These are the things you have to document in your order for pharmacy and for our CPG. If the patient's missed a few days of methadone, it's recommended to decrease their dose. If they've missed between 3 and 5 days of their methadone dose, you cut it in half. If they've missed more than 5 days, you just treat it as a new start and start with that 30 milligrams again. If for whatever reason the patient is NPO, you can do IV methadone. It's a 50% dose reduction. I actually did not confirm with Samit if we have IV methadone here or not. I don't know the answer to that. But and then for patients with QT prolongation, the recommendation in our CPG is if their QT is between 500 and 550, you just reduce their dose by 50%. You do not have to completely discontinue it. And obviously treat your reversible causes. And then I can talk very, very briefly about naltrexone. I do not like naltrexone. This is very much my bias. There is no real evidence that there's a survival benefit to naltrexone. But essentially, this is just an antagonist. It blocks the effects of opioids. There's both an oral form and an injection form. The injection form is FDA approved for opioid withdrawal. The oral form is not. Also effective for alcohol use disorder. I don't like this because for a couple of reasons, but it's often offered as the only form of treatment for patients that are incarcerated who have high rates of trauma recidivism. And it also blocks the effect of any opioid receptors, so, or of any opioid whatsoever. So these patients who are on naltrexone, especially if they have like the injection, it's a depot effect. If they break a leg, if they get shot, if they have traumatic injury, you're very behind the 8 ball on your pain control. So I don't love naltrexone because I don't think it works, and I think it creates these sort of ethical issues for patients who are at high risk of trauma recidivism. It also has an increased risk of overdose when discontinued, the same as other treatments, but probably a little bit pronounced. That said, if your patient really wants it or is on it, this is something that anyone can prescribe, and you can prescribe in the clinic setting. It's an IM injection. If your patient wants to be continued on it, I would say don't argue with them, because again, if they come off it, it does have increased risk of overdose. And this is pretty straightforward. It's just a 380 milligram intramuscular injection every 30 days. Make sure it is intramuscular. It can have pretty bad skin reactions if it's subcutaneous. If your patient wants to be initiated on this, basically you have to make sure they are fully detoxed of opioids before you start it, or they can have precipitated withdrawal. The general recommendation is 7 days off of short-acting and 10 to 14 days off of long-acting opioids. And the recommendation is you Narcan them, basically do a Narcan challenge before you do the naltrexone to make sure they don't have any withdrawal symptoms. So where do you go for help? These are sort of my go-to resources. The DACS, the District Addiction Consult Service, is great. It's run out of the University of Maryland. It's free. I love them. They're so sweet, and they're really helpful. There's a National Clinician Consultation Center, which is also sort of a warm line available for resources. And then if you just want like a quick resource for what can I give my patients, California Bridge is my favorite resource by far. I use them for everything. Most of MedStar's like ER policies are just stolen from California Bridge and changed to MedStar branding. They're fantastic. I love their resources. And then as far as patient resources, making sure your patients have the things they need, both for treatment, but also for sort of harm reduction. So even if your patients aren't interested in buprenorphine or aren't interested in other sort of treatment options, make sure they have access to needle exchanges, make sure they know where to get Narcan. We can obviously give them Narcan in hand, but there's also free Narcan throughout the city. HIPS is a really good community-based harm reduction organization that actually will offer buprenorphine and other medication-assisted treatment. If you're looking for sort of other recovery services, Thaddeus is always my go-to resource for where should this patient go for treatment. I also only work nights, so if Thaddeus isn't here, these are sort of your online resources. And then if your patient's having trouble paying for their medication, there is a program called the BUP-DAP program, which is the drug assistance program, which there are at least 2 pharmacies in DC where they should just be able to get their buprenorphine for free with city assistance. So you have to do an application form for that, but there is access to patients who have trouble paying for their medication. And then if you haven't already seen it, I always forget this exists, but the MedStar Health Social Needs resource page is a great resource for housing, for food stability. And then it also has sort of resources for mental health treatment and for substance use treatment. And that's just, I think, socialneeds.medstarhealth.org. That's always a good resource. I think that's all for me. That was a ton of buprenorphine all at once. Any specific questions I can answer for anybody?